Hello, and welcome to this training presented by the Leukemia and Lymphoma Society of Canada, Managing Myelodysplastic Syndrome and the Nurse Practitioner's Role, Focus on Blood Transfusion. My name is Natasha Sani, and I'm the Community Service Lead for the BC and Yukon region at the Leukemia and Lymphoma Society of Canada. Before we start on the main presentation, I'd like to take a moment to share with you our mission and present some resources that may be helpful for you and the people you serve. At the LSC, our mission is to cure blood cancers and improve the quality of life of those touched by blood cancer and their families. We listen attentively and with compassion to the challenges of our community, pointing them to the information specific to the type of blood cancer or treatment. We help them get organized in managing and taking charge of their care, and we can identify services that would be beneficial for them. Please visit bloodcancers.ca to find the contact information of the community service lead in your area. We also offer a continuing education program that you can join free of charge. You can register to one or more trainings that you can do at your own pace and receive an electronic certificate of participation. All of our trainings are offered by experts. More than 1,500 healthcare professionals are using the platform, and there are over 40 trainings available. Available to you are training on blood cancer, treatments, psychosocial aspects of cancer, and more. We are adding to our trainings on a regular basis. Available online are all our educational tools and resources. These are vetted by experts for all the main types of blood cancer, treatments, secondary effects, and more. Our material is available in multimedia formats to address the variety of needs and preferences of individuals. They include digital disease booklets, fact sheets, podcast episodes, animated videos, and webcast recordings. By visiting our website, you can place an order for materials that will be sent directly to your cancer center or clinic. These materials can be ordered include disease booklets, service posters, palm cards, and much, much more. All of these tools and more can be ordered or downloaded through our website. You can order our tear pads for easy reference to our services or blood cancer literature to inform those affected and the families you support. It's all very easy to do and free of charge. Most of our educational materials can also be downloaded through our website. With this handy electronic form, you can order materials to be shipped to your location. It just takes a few clicks. If you have any questions, please reach out to the community service leader in your region. We are always here to help. Emotional and practical support is a priority for the LSC. Our peer support program has been identified as a key service, but many do not know about it. Trained volunteer survivors who are 1 year post-treatment share their stories with newly diagnosed patients or those facing a new treatment option. Age, gender, diagnosis, and treatment are all considered to ensure the best match. This program helps to build hope, alleviate anxiety, and create realistic expectations. We also have professionally facilitated virtual groups. These support groups, offered coast to coast, give the opportunity to the blood cancer community to connect with others who are facing the same challenges from the comfort of their own home. Each participant builds connection through group discussions, sharing coping tools and information, and it helps break isolation. To learn more, visit our website, www.bloodcancers.ca, or reach out to the community service lead in your region. It is now time to introduce our speaker today, Kristen Lewis, who is a nurse practitioner at the Princess Margaret Cancer Centre. Over to you, Kristen.
Thank you so much for that introduction, and welcome to this presentation on managing myelodysplastic syndrome with a focus on blood transfusions. My name is Kristen Lewis, and I'm a nurse practitioner in complex malignant hematology. Today's objectives are to provide an overview of myelodysplastic syndrome, reviewing the practicalities of blood transfusions, and then some case studies to explore common complications of packed red blood cell transfusions. MDS is a heterogeneous blood cancer that begins in a particular type of cell in the blood and bone marrow called a myeloid cell. When the DNA in these cells is damaged, they do not develop properly and become abnormal in size, shape, or appearance, called dysplasia. MDS is characteristic by a buildup of these dysplastic immature blood cells called blasts in the bone marrow. The accumulation of these blasts can lead to fewer mature red blood cells, white blood cells, and platelets in circulation. This causes cytopenias and leads to symptoms such as fatigue, infection, spontaneous bleeding, and easy bruising. As well, patients can be more susceptible to infections. Approximately 30% of MDS patients transform to acute myeloid leukemia, or AML. A few statistics about MDS. The median age of diagnosis is 77 years. Up to 40,000 Canadians are living with or in remission from MDS. Up to 6,000 Canadians will be diagnosed with MDS in 2024. 57% of patients will fall into the very low, and intermediate risk category. 43% will be high or very high risk. There is no direct cause of MDS. However, several known risk factors increase the likelihood of developing MDS. Age is one of the most important risk factors for MDS. The incidence of DNA damage increases with age. Older age is associated with a higher risk of developing MDS, as well as with worse outcomes. Males are more likely than females to develop MDS. Patients who receive chemotherapy or radiation for potentially curable cancers, such as breast cancer, testicular cancer, or lymphoma, are at a higher risk of developing MDS up to 10 years after their treatment. Approximately 10 to 20% of all MDS cases are treatment-related. Exposure to benzene and certain chemicals used in the petroleum and rubber industries have shown to increase the risk of myelodysplastic syndrome and other hematological cancers. Exposure to large levels of ionizing radiation may also be associated with increased MDS risk. Certain genetic syndromes, which stem from mutations in pathways responsible for DNA replication and repair, can lead to MDS. These include Fanconi's anemia, Bloom syndrome, Down syndrome, Diamond-Blackfan anemia, and proximal nocturnal hemoglobinuria. There are also familial risks and the risk of smoking. Patients with lower risk MDS will typically be diagnosed with an abnormality in blood cell counts during a routine visit to their general practitioner. Higher risk MDS patients may present with symptoms such as fatigue, weakness, and shortness of breath. Many of these symptoms are anemia related, as anemia is found in 80 to 85% of patients and is the most common cytopenia for patients with MDS. They may also notice bruising or bleeding. Bone marrow and blood assessments are key to MDS diagnosis, and initial evaluation requires careful assessment of the peripheral blood smear and bone marrow biopsy. They are evaluated for the presence of abnormal number of blasts, the abnormal morphology of cells in the bone marrow. Genetic testing is also performed, such as cytogenetics, the study of chromosomes, and molecular studies, the study of the genes at the DNA level. Other potential causes of cytopenias and concomitant illnesses should also be evaluated. In healthy people, there should be no blast cells in the circulating blood, and blast cells should make up no more than 5% of all bone marrow cells. In myelodysplastic patients, up to 20% of cells in the bone marrow may be blast cells. If the blast cell count rises above 20%, this is considered acute myeloid leukemia, or AML. Patients with 10% to 19% bone marrow blast cells may also be diagnosed with AML and not MDS if they have certain genetic mutations more typically found in specific types of AML. Since AML can be a difficult disease to diagnose, patients may want to get a second medical opinion by an experienced hematopathologist before beginning treatment. There are multiple subtypes of MDS as defined by the WHO, which was updated in 2022. These subtypes are determined by the following: low blood cell counts, either red blood cells, white blood cells, and/or platelets; dysplasia, meaning cells that have an abnormal shape or size; the number of blast cells, which are immature blood cells in the blood and bone marrow; changes to the chromosomes and genes in bone marrow cells that are associated with myelodysplastic syndrome. More than 80% of patients have at least one gene mutation. However, there isn't one single causative mutation. Chromosomal abnormalities are present in approximately 50% of MDS patients. MDS is a heterogeneous disease where a hematopoietic stem cell acquires a DNA mutation, resulting in dysplasia. The results of the blood and bone marrow tests are used to determine the subtype of MDS described by the World Health Organization and the International Consensus Classification Guidelines. The WHO and the ICC classification systems both recognize significance of bone marrow blast counts, the extent of dysplasia, and cytogenetic and molecular abnormalities. But they have differences in terms of their overall organization, category labels, diagnostic criteria, and distinctions between MDS and AML. For the WHO 2022, a cutoff of less than 20% blasts in the blood and bone marrow delineates MDS from AML. For the ICC 2022, patients with 10 to 19% blasts were defined as AML/MDS, a new designation. This was done to acknowledge borderline cases between AML and MDS and allow patients to be eligible for MDS or AML clinical trials or treatment approaches. The revised International Prognostic Scoring System allows patients to undergo risk stratification. The IPSS-R was derived from the original IPSS to incorporate more detailed criteria such as cytogenetic subgroups, separate subgroups within the marrowblasts of less than 5% group, and depth and number of cytopenias with defined cutoffs. IPSS-R allows for the calculation of median overall survival along with estimation for time to AML transformation. The IPSS-R remains the preferred prognostic system for clinical practice as well as the standard for clinical trials. IPSS-R uses 5 variables to generate a risk score to stratify patients into one of the 5 risk groups. Treatment guidelines are divided by risk into 2 broad subgroups, as defined by the IPSS-R score: low risk and higher risk MDS. There are many treatments for MDS. A hematologist will create a plan that is specific to each patient based on risk stratification and goals of care. The goals for low-risk MDS versus high risk are different. With low-risk MDS, the goal is to improve blood counts to increase transfusion independence, lower the risk of infection, and improve quality of life. There are various agents that are indicated based on the features of the particular patient to help accomplish these goals, including ESAs, lenalidomide, luspatercept, or Inqovi. Goals for high-risk MDS are to slow disease progression and improve survival for patients who are not candidates for allogeneic stem cell transplant. An allogeneic stem cell transplant is a potential option to achieve cure for myelodysplastic syndrome. Physicians will refer to clinical treatment guidelines, including those provided by the European Society of Medical Oncology, European Leukemia Network, and the National Comprehensive Cancer Network to support their treatment approach. Currently, hematopoietic stem cell transplant represents the only curative treatment option for patients with MDS, but only a minority of MDS patients are eligible. Many older patients and patients with comorbidities are unable to tolerate the intensive treatment. Physicians instead aim to prevent or slow the disease from developing into AML and control the disease in the bone marrow using hypomethylating agents, which represent the current standard of care for high-risk MDS patients. Patients with high-risk MDS who are ineligible for allogeneic stem cell transplant have fewer treatment options. The only approved therapy is azacitidine monotherapy. Furthermore, patients whose disease progresses or who experience unacceptable toxicities have limited options for a subsequent therapy. If a clinical trial is not available, the only alternative is supportive care. Most of the supportive care for MDS is focused on the management of cytopenias. Anemia is the most common cytopenia and occurs in 80 to 85% of MDS patients. Symptoms include fatigue, weakness, lightheadedness, and shortness of breath. Red blood cell transfusions can help improve the symptoms of anemia. Iron chelation therapy may also be used to remove the excess iron that accumulates in the body due to red blood cell transfusions. Approximately 30% of patients will also have thrombocytopenia. Manifestations of this include easy bruising and excessive bleeding. Treatment options include platelet transfusions, thrombopoietin mimetics, antifibrinolytic agents, androgen therapy, or platelet growth factors. Infection is a major cause of morbidity in MDS. Patients may benefit from prophylactic antimicrobials or hematopoietic growth factors. Blood transfusions are an important part of managing the symptoms of MDS. As red blood cells and platelets are made in the bone marrow, the spongy tissue inside the bones. The damage from MDS prevents the bone marrow from making enough healthy red blood cells and platelets. Having too few red blood cells is called anemia, and it causes symptoms like fatigue, shortness of breath, and heart palpitations. Having too few platelets is called thrombocytopenia. It can also cause bruising or bleeding. The frequency of blood transfusions for MDS depends on patient red blood cell and platelet counts. Some patients with MDS need transfusions every couple of weeks. Others can go months without needing a transfusion. Platelet transfusions, when required, are given more often because these blood cells can only survive for 7 to 10 days in the body. Other medications that can be used to avoid transfusions act to stimulate hematopoiesis. Erythropoietin-stimulating agents mimic the naturally occurring hormone erythropoietin that is made in the kidneys and acts at the bone marrow to stimulate red blood cell production. Erythroid maturation agents, such as luspatercept, can be used after failure of ESAs. White blood cells can be stimulated by GCSF to avoid the complications of infections, but prolonged use can theoretically increase the risk of leukemic transformation. Platelet stimulating agents have a role in the supportive care of selected MDS patients with severe thrombocytopenia, but their use is not widespread and requires careful consideration of risks and benefits. Ongoing research aims to clarify their safety and efficacy in this population. While blood transfusions can provide considerable benefit to MDS patients to help their symptoms, there are side effects to be considered. An allergic reaction is the most common type of blood transfusion complication. It happens when patients' bodies react to certain proteins or other substances in donated blood. Symptoms include hives and itching, which can be treated with antihistamines. An acute immune hemolytic reaction is a very serious reaction that happens when patient's blood type and donor's blood type don't match. The immune system attacks the new red blood cells, which makes them break open and release toxins into the blood. Acute immune hemolytic reactions are rare today because donors and recipients are matched so carefully. This type of reaction requires immediately stopping the blood transfusion. Lung complications of both transfusion-related acute lung injury, or TRALI, and transfusion-associated circulatory overload may also occur. Rarely, the transfusion activates immune cells in the lungs, which cause fluid buildup and lung damage. TRALI is the more common in patients who are already very sick, requiring a blood transfusion. The first step of nursing care is the nursing assessment, during which the nurse will gather physical, psychological, emotional, and diagnostic data. We begin by reviewing the patient's health history. First, we determine the patient's indication for blood transfusion. Assessing the patient for any signs of bleeding or trauma, symptoms may or may not be obvious. Signs of internal bleeding may include severe hypotension, pallor, a swollen abdomen, respiratory distress, and changes in consciousness. We also review the records for any history of blood transfusions. Check the patient's record for a history of blood transfusions and its indications. A possible reoccurrence of the cause may have led to the current blood transfusion. Assess for medical conditions related to bleeding. Severe anemia, sickle cell disease, hemophilia, and certain cancers increase the need for frequent blood transfusions. Identify the patient's known allergies. The patient may need pre- and post-transfusion medications to avoid allergic reactions if they experienced them previously with blood transfusions. Assess for previous transfusion reaction. Transfusion reactions can occur during and after the transfusion, as in a delayed reaction. Symptoms of transfusion reactions include breathing difficulties, chills, fevers, urticaria, and hypertension. Ask about the patient's religion. Jehovah's Witnesses may refuse to receive blood transfusion or blood products. It is the patient's right to refuse treatment, though the nurse should educate on the risks of refusing necessary medical treatment. Assess for any comorbidities or conditions that may be affected by blood transfusion. Take caution when administering blood products to patients with comorbidities such as congestive heart failure or kidney dysfunction, as the patient may experience fluid volume overload. Obtain baseline vital signs by monitoring temperature, respiratory rate, heart rate, and blood pressure prior to initiating the transfusion. The nurse should closely monitor the vital signs during the transfusions to identify a reaction or complication. Perform a physical assessment. To establish baseline data, focus on the CNS, respiratory, cardiovascular, and integumentary systems. Symptoms of pallor, dyspnea, tachycardia, hypotension, and lightheadedness should improve with blood transfusion. Begin the transfusion slowly. Start packed red blood cell infusions at a slower rate for the first 15 minutes, as most transfusion reactions happen within this time frame. Refer to your facility's policy for a specific rate. Remain with the patient at the start of the transfusion. Observe the patient for the first 15 minutes upon starting the transfusion. Note any clinical indications of a transfusion reaction. If no reaction occurs, the nurse should increase the transfusion rate. Transfuse within the recommended time frame. The blood transfusion should start within 30 minutes upon release from the blood bank. Each unit should be transfused within the following time frame. For packed red blood cells, between 2 to 4 hours. For any platelets and plasma, 30 minutes to 1 hour. Continue to monitor for transfusion reactions. The nurse should continue to monitor the patient and obtain vital signs hourly until the transfusion is completed and at the completion of the transfusion. Some hospital facilities may require ongoing monitoring for the next 24 hours. Immediately act if a transfusion reaction is suspected. Stop the infusion if a transfusion reaction occurs. Follow the protocol while managing symptoms. Document the necessary transfusion reaction form and incident report. Bring residual blood and all equipment to the blood bank for laboratory testing. Obtain blood and urine samples from the patient for further investigation. Flush the IV line after use. Keep the vein open with normal saline to prepare for additional units of blood or other medications. Document the transfusion. Complete all forms as specified by the facility's policies. Documentation includes the following: transfusion record form, vital signs and reaction monitoring, observations during and at the completion of the transfusion, and documentation of any incidents of transfusion reactions. Post-procedure, the nurse should continue to monitor for signs of transfusion reaction. Inform the patient about transfusion symptoms. Continue to evaluate and monitor for any clinical signs of reactions within 24 hours after the transfusion. Advise the patient when to seek medical attention. Advise the patient to seek attention if any of the following transfusion reactions occur: fever, respiratory difficulty or wheezing, cardiovascular symptoms such as palpitations or chest pain, any nausea or vomiting, any skin changes such as rashes, hives, or itchiness, as well as any severe back pain, bleeding, or chills. Recheck the vital signs post-transfusion. Patients receiving scheduled transfusions in an outpatient setting are often required to remain for 1 hour post-transfusion to monitor for reactions. Ensure the patient's vital signs are stable before discharging. Finally, schedule the patient for reevaluation of blood tests. In instances of frequent transfusions, reevaluation of blood tests, such as the complete blood cell count, is necessary to monitor the effectiveness or need for another blood transfusion. Let's review some patient cases to understand a bit more about common reaction scenarios. Let's begin with Mr. Gump. He is a 65-year-old man with a recent diagnosis of myelodysplastic syndrome. He presents with symptomatic anemia characterized by fatigue, pallor, and mild dyspnea on assertion. His hemoglobin level was noted to be 68 grams per liter, necessitating a transfusion of packed red blood cells to help his symptoms and improve his oxygen carrying capacity. Mr. Gump has a history of hypertension, diabetes, chronic kidney disease, and is taking multiple medications, which include an antiplatelet therapy and apixaban. He has no known prior history of blood transfusion reactions and no significant allergies. Approximately 40 minutes into his transfusion, he unfortunately develops chills, rigors, and fever with a measured temperature of 38.9. He reports at the same time feeling flushed and mildly nauseated, but denies any shortness of breath, chest pain, and he has no visible rash. His vital signs during the reaction show a blood pressure of 132 on 80, a heart rate of 92, and respiratory rate of 18 breaths per minute. Our first step is to stop the transfusion and maintain IV access. An order for acetaminophen was obtained and administered to Mr. Gump. Blood work was sent for a direct antiglobulin test, haptoglobin, and repeat CBC. Blood cultures were sent to rule out infection as a cause of the fever. Urinalysis was also sent to look for signs of hemolysis. What could be possibly happening to Mr. Gump? The most likely cause of fever during this transfusion is a febrile non-hemolytic fever. Other possible causes include a septic transfusion reaction, which is why we did blood cultures, and the blood product should be tested as well for bacterial contamination. A hemolytic reaction is also possible. Febrile non-hemolytic transfusion reactions occur in about 1 in 300 units transfused. Fever is defined as an increase in temperature of 1 degree. If this is detected, the transfusion should be stopped and complete vital signs should be assessed. More serious signs of reaction could include fevers with rigors, unstable blood pressure, nausea, or vomiting. The provider and blood bank should be notified to determine any other investigations required. If the patient is stable, transfusion may continue. If there is suspicion of infection or the patient is neutropenic, IV antibiotics should be initiated. Let's move on to Mrs. Brockovich. You are administering a transfusion of packed red blood cells to Mrs. Brockovich, who is diagnosed with MDS. While monitoring during the transfusion, you note the following symptoms: crackles or rales on auscultation, jugular vein distension, an elevated blood pressure, dyspnea, and adventitious breath sounds. What would be the possible diagnosis for Mrs. Brockovich? She certainly has evidence that she has excessive fluid volume. Circulatory overload can occur during a blood transfusion procedure when blood products are administered at a rate greater than what the circulatory system can accommodate. Mrs. Brockovich is experiencing symptoms of excess fluid volume or transfusion-associated circulatory overload. TACO is defined by acute or worsening of respiratory compromise with or without evidence of pulmonary edema. It can occur during or up to 12 hours post-transfusion. The symptoms can include dyspnea, orthopnea, tachypnea, hypoxia, crackles or rales on assessment, and elevated JVP. There may also be noted hypertension, peripheral edema, and weight gain. A chest X-ray may demonstrate pulmonary edema. Let's assess Mrs. Brockovich. We're going to start by assessing and monitoring the patient's intake and output. Intake and output can indicate the patient's fluid volume status. If output does not match what is being transfused, the patient may be experiencing fluid volume overload. On physical exam, breath sounds may demonstrate crackles and rales combined with dyspnea, which can also indicate circulatory overload. We will continue to assess and monitor the patient's vital signs. Increased blood pressure and sinus tachycardia are early signs of fluid volume excess. Let's now consider the patient's history. A patient with a history of congestive heart failure or other cardiopulmonary conditions may need to be monitored more carefully. These are some interventions we can expect for Mrs. Brockovich. Diuretics are usually indicated in cases of excess fluid following a blood transfusion, as that helps in the excretion of excessive fluids in the body. For patients with a history of CHF, diuretics may be ordered prior to the transfusion to prevent fluid volume overload. Strict adherence to the rates of IV fluids is vital, as it can help avoid excess fluid volumes. Transfuse blood at the slowest possible rate to meet protocols but prevent fluid overload. Provide supplemental oxygen as needed. Providing oxygenation will help facilitate breathing during circulatory overload. The patient should be placed in a semi-Fowler's position. This position allows for the proper evaluation of jugular vein distension. It also offers ease of breathing for optimal chest and lung expansion. Finally, elevate the edematous extremities, if present. Elevation of affected body parts can reduce and promote the increased venous return to the heart. To help mitigate the risk of TACO, an assessment of Mrs. Brockovich's risk factors should be completed. Does she have any pre-existing cardiac or renal issues? Transfusion should be given at a slower rate for at-risk patients, and a one unit at a time approach should be considered. A diuretic as a pre-medication is a common practice as well to avoid fluid overload. Mr. Magoo is our next patient. He is a 72-year-old man with a history of type 2 diabetes and recently diagnosed with myelodysplastic syndrome, presenting with symptomatic anemia. His hemoglobin today is 65 grams per liter, and he is seen in the transfusion clinic for transfusion of 2 units of leukoreduced packed red blood cells. The patient has no prior history of transfusion-related complications. His pre-transfusion assessment includes vital signs showing a blood pressure of 140/85, a heart rate of 80, a respiratory rate of 16, and oxygen saturations of 96% on room air. The first unit of packed red blood cells was transfused without any incident. Unfortunately, approximately 30 minutes into the second unit, the patient develops an acute respiratory distress that is characterized by dyspnea and tachypnea. His respiratory rate has increased to 20 breaths per minute. He has now developed hypoxia with oxygen saturation dropping to 86% on room air. On physical exam, we can hear bilateral crackles, but he has no evidence of hives, fever, or volume overload. as evidenced by his jugular venous pressure and peripheral edema being normal. What would be the possible diagnosis for Mr. Magoo? Mr. Magoo is likely affected by TRALI, or transfusion-related acute lung injury. TRALI is caused by the activation of recipient neutrophils in the pulmonary vasculature, which is triggered by donor antibodies in the plasma of transfused blood products. This causes capillary permeability or leaking and results in non-cardiogenic pulmonary edema. It is underreported, so it's difficult to know the actual incidence, but it could be anywhere from 1 in 1,300 to 1 in 250,000 units transfused. It typically occurs within 6 hours of transfusion and then resolves in 24 to 72 hours. If TRALI is suspected by the appearance of symptoms like dyspnea or hypoxia, the transfusions should be stopped immediately. Provide supportive care with oxygen therapy. Up to 70% of cases may require mechanical ventilation. Steroids and diuretics have been known to have limited benefit. Donor and recipient testing is key to limiting reactions in other recipients. Strategies to prevent TRALI are focused on limiting the transfusion of products that may elicit this reaction. Plasma for transfusion is typically from male donors or females who have not been pregnant. Donors who are implicated by a TRALI reaction are unfortunately no longer used. Ms. Jones is a 55-year-old woman with a history of myelodysplastic syndrome presenting to the emergency department with worsening fatigue, pallor, and dizziness. Her hemoglobin level is 70 grams per liter, and she's admitted for a transfusion of 1 unit of packed red blood cells. The patient has no prior history of transfusion reactions, but reports mild seasonal allergies managed with over-the-counter antihistamines. Her vital signs are all at her baseline, and she has no febrile prior to her transfusion. Approximately 20 minutes into the transfusion, the patient reported itching on her arms and legs. On examination, she had a generalized urticaria, as in a raised erythematous pruritic wheals rash on her arms and chest. Luckily, she has no signs of respiratory distress or hemodynamic instability. Her vital signs remain stable at her baseline. What is the possible diagnosis for Mrs. Jones? Mrs. Jones is having symptoms of an allergic reaction to the packed red blood cells. We will immediately stop her transfusion and maintain venous access with normal saline. Diphenhydramine is administered to help alleviate pruritus and hives. Her symptoms quickly resolve, and she was reassessed prior to restarting the transfusion. If the reaction had been more severe, we would have held the transfusion and notified the blood bank for further testing. Allergic reactions are typically related to the plasma component of transfusions. They may occur with a spectrum of symptoms, from mild symptoms of hives, but can be more severe with respiratory involvement, GI symptoms, hypotension, and even anaphylactoid reactions. Ms. Jones may benefit from pre-medications such as diphenhydramine or corticosteroids. We might also consider giving her washed blood products with persistent allergic reactions. Other transfusion-related reactions can include isolated hypotension caused by bradykinin release, but this can also be representative of the symptoms of sepsis, allergic reaction, or acute hemolytic anemia. Hemolysis can occur for a long period after transfusion, up to 28 days post. This is a result of the development of recipient antibodies against the transfused blood products. This chart lists the risk of transfusion-related reactions and side effects. There are many different types of reactions that occur, with some being more common and others being quite rare. Finally, to summarize, myelodysplastic syndrome is a blood cancer that begins in a particular type of cell in the blood and bone marrow called a myeloid cell. During the development of MDS, the buildup of blasts in the bone marrow decreases the production of functional blood cells, such as red blood cells, white blood cells, or platelets. It typically affects older adults with a median age of diagnosis of 77 years. The diagnostic workup will include blood and bone marrow assessments, as well as genetic testing. Patient and disease-specific characteristics will affect the prognosis, including the MDS classification, the severity of the patient's symptoms, their overall health, and their MDS risk stratification. Current treatment pathways for higher risk MDS patients include allogeneic stem cell transplant, hypomethylating agents, and supportive care. Supportive care can include blood transfusions, making it an important background. Supportive care can include blood transfusion. Administering blood transfusion is a common nursing intervention. There are many nursing protocols for blood transfusions, and it's important to explore the procedures before and after transfusion, safety measures, and recognizing potential complications. Here are some references that are helpful to learning about MDS and managing blood transfusions. Thank you so much for your attention today.
Thank you so much, Kristen, for this presentation. To you who are listening to us, I hope you enjoyed it as well. We invite you to access the continuing education platform to review the other training courses. This event was made possible thanks to the support of AbbVie. And finally, I'd like to remind everyone that we are here for the blood cancer community. Please do not hesitate to order a tear pad for free and contact us if you need more information or support. We hope you have a wonderful rest of your day. Thank you.